always ask, but I really love this. It's what I'm passionate about.
Super.
Well, everyone, it is 9:00 a.m. and we'd like to welcome and thank each person on this call for joining us for the Telemedicine Echo Call. I'm Cece Vengel with Missouri Telehealth Network and Show Me Echo. And we are very excited this morning to have a special guest, Joseph Johnson, who is with Project Echo at Oklahoma State University Center for Health Sciences. And I will not take a long time on introductions because he has much material to present to us this morning. Dr. Johnson?
Well, thank you very much. Thank you for having me, first of all, and thank you for allowing me to share a little bit about what's been happening at Oklahoma State University and some of the echo lines that we have going. I am going to try to jump right in here and share some slide information with you, and see if I can get this right up to the very beginning here, and we will go from there. Can you see the slides okay?
Yes.
Okay, and why is it not in the slideshow from the beginning? There we go. All right, super. I don't know which view you're seeing. Hopefully you're seeing the regular large slide. So
we're seeing the presentation view.
Okay, now how do I do that? You can make the display settings. Let's go to swap. How's that?
Perfect.
All right,
Perfect.
great. All right, super. So Oklahoma State University, like University of Missouri, and that got started with Echo when they saw the obvious need throughout our 77 counties. We launched our first Echo program January of 2017. At that time, I was the associate dean building this beautiful simulation center and working on the 3rd and 4th year clerkships. And I had the background previously as being the department chair for the obstetrics and gynecology department and the residency program. When I came here in 2006, we had a total of 4 residents in 1 hospital. We now have 7 hospitals and 20 residents. And so moved over here to handle the clerkship program. And Dr. Shrum, our dean at that time, was like, you know, I was just introduced to something called Project Echo. And literally, she sat on it for a year. And a year later, she came to me and said, do you think we could do something like this? Well, at that time, we were already working with the ANGELS program for high-risk obstetrics and gynecology out of the University of Arkansas. And so for me, it was like, okay, we'll just add it to it. So that was in 2017, and since that time we've grown 18 programs, and as soon as we launched the high-risk, well, we've launched the high-risk OB, but we've got the nursing homes going on, which will be 6 additional ECHO programs at that time. I have no disclosures. I've got a family out there. I'm like, burn the money, send it to me, pay for those 15 grandchildren, of which 8 of those grandchildren were delivered by my residents. So I usually like to say, can you imagine a program, an educational type of a platform that can actually touch the lives of all Oklahomans, all people from Missouri, Arkansas, you know, Kansas, Texas, wherever we see the need to be able to provide excellent information, specialty related care to those rural communities. And that's where ECHO came along. So this is our current building. In the bottom floor there, that little kind of window thing you see there, that's this ECHO room that I'm sitting in currently. We will be moving out of this to one of those big white buildings in the backdrop, and we're going to have the top 6 floors of that building. ECHO will be on the 12th floor, and we will actually be quadrupling the platform that we currently have for space. But we look at this as being an education platform. Education is being used for ECHO throughout medicine as well as throughout education. With the COVID crisis that we just had, we have jumped into helping the school leaders, the teachers, the flipped classrooms, parental engagement, and that for ECHO related lines. You're familiar enough with ECHO to understand that there are the 4 key principles that we're trying to deal with. That we want to use advanced technology, our A, Going into the B, we're looking for best practice models for whatever topic it is that we are dealing with. We want to make sure that this becomes not telemedicine, but a teleeducational, case-based mentorship type learning. And that's where that extension for community healthcare outcomes comes. And then maintaining a good database to make sure that we see that what we're doing is actually becoming effective. It obviously requires a lot of input from a lot of different people to make it happen. In our state, we've been very fortunate to be able to get it from the very top down. And I'm going to share just a quick video.
Good morning. I'm so excited to see you here on this OSU Project ECHO COVID-19 session. Thanks to Dr. Casey Schramm and her visionary leadership as my Secretary of Science and Innovation and as President of OSU CHS in bringing Project ECHO to Oklahoma. By utilizing technology, OSU physicians, nurses, psychiatrists, and others can share evidence-based practices and knowledge with healthcare providers across our state. And most importantly, to the frontline workers in rural Oklahoma who are dealing with this pandemic with limited resources. The innovation solution of OSU Project ECHO and the COVID-19 sessions make resources and expertise available to all 77 Oklahoma counties. This morning, we are presenting to you the resources and information you need as part of the state's hospital surge plan to be prepared for the peak of the COVID-19 outbreak. I want to thank each of you for the hard work you are doing for your communities to keep Oklahomans safe and healthy. God bless you, and God bless the great state of Oklahoma.
So with Governor Stitt basically having leadership from the very top supporting us, we have senators, legislators that are totally on board with the ECHO-related model within the state, has been able to help us launch multiple ECHO-related lines. We started out with adult mental health and pediatric obesity were our first ECHO lines that we launched. The psychiatry, because of a large grant and part of the addiction money that came out of the opioid settlement within the state, we now have psychiatry programs in addiction medicine, which is a partnership with 12 and 12 and the Betty Ford Foundation. So we're handling both opioid as well as alcohol. Because of those relationships, we'll get into how it's applied to the high-risk OB, because the collaboration between medical assisted therapies in pregnancy for individuals that have found to be abusing opioids in pregnancy worked into that program. We have a pediatric emotional behavioral health, infant mental health, and developmental childhood development. Forensic psychiatry came out of that psych program. Obesity medicine in both pediatrics and now adults. HIV, hepatitis C actually grew into a multi-virology program, one handling the Indian nations through Dr. Mara out of the Cherokee Nation, and also Dr. Mara running the OSU and Oklahoma state-related hepatitis C programs. Obviously, COVID-19 came on board in March, which developed into multiple COVID lines. COVID lines to handle the legislature, COVID lines to handle the Department of Education and going back to school, our regular medical COVID line. We're all very instrumental from that standpoint. Coming out of the educational relationships came teleeducation, which looks at leadership development, special education, looking at all the ACES guidelines within kids, teleedge, which was taking a look at our bottom 100 schools and trying to increase them to the remaining standards, and a new program that just started called teleengage because of the flipped classroom and kids learning on the internet at home, how to engage the parents in the responsibility of making sure that their children were following through. We also worked with the Alzheimer's Association locally, two very large philanthropists helped us launch that, and that has been turned over totally to the Alzheimer's Association in Chicago and working through those areas. With the COVID-19 and nursing homes, we anticipate 6 new launches there. But now what we did was, me being an obstetrician gynecologist by nature, I have been trying to take a look at how do we handle the high-risk obstetrical needs throughout our state. In Oklahoma, we have many counties that do not have an obstetrician. So what we wanted to do was look at our state perinatal task force and what we were trying to accomplish through the state and bring on team members that would meet that need. So what we did was we brought on Dr. John Stanley, who's a maternal fetal medicine physician out of Oklahoma City. We brought on 2 general high-risk OB doctors, Dr. Aaron Brown and Dr. Carlos Guevara with the OSU OBGYN residency program, and Dr. Regina Lewis, who is a high-risk OB family practitioner doctor, does her own C-sections and things of that nature. So it's basically being housed out of Oklahoma State University, but meeting the 66 counties. Well, why did we feel we needed to do that? First of all, over the past 18 years, we are still having a high percentage of women that are dying every year and having morbidity and mortality related to obstetrical care. So not only do we want to look at the high-risk areas associated with just being pregnant, but we also wanted to look at those issues associated with substance use disorder within pregnancy, because we understand the neonatal, postnatal syndrome is very, very costly to this country. Also, the problem of taking care of women that are currently pregnant with high risk is very costly, especially when they're in obstetrical deserts. March of Dimes listed Oklahoma having 41 of the 77 counties having no maternal care out there. So you either have a PA, a nurse practitioner, a family practice doctor that's identifying these people pregnant, following through a portion of their pregnancy, and then sending them off to a more high-risk center for the actual delivery. Well, by the time they get there, it's almost too late because a lot of the damage has been done that hasn't been recognized. So knowledge is the key. Being able to put together a team-based approach to provide the quality care is certainly what these strong partnerships and complementary roles are associated with. We want to make sure we have good quality specialists that can take a look at the literature, make sure that evidence-based literature is getting out there, putting it into our box-related systems to be able to provide it, make sure that our mid-level providers, primary care physicians, have the same knowledge base and tools utilized to be able to get the job done. So deliberate practice through ECHO training provides all of those rural providers with the proper training, with a mentorship. We liken our ECHO programs very much to postgraduate residency continued education from the standpoint that you have somebody mentoring you. It's not like a CME lecture where you go to a CME, you listen to a bunch of topics, you go back into your private practice and you go, how in the heck do I put this into place? By doing it through the ECHO model with the mentorship, they are getting constant learning, they're presenting their patients, they're getting their questions answered until they truly achieve a mastery. Missouri is no different, and Kansas and those adjoining states to Oklahoma are no different than us. We have a lot of disparities that go out throughout the state. When you take a look at areas in the southwest or southeastern portion of the states, I mean, they are really deserts from the standpoint of medical education and specialty related education, whether it be racial or ethnic related problems occurring in there. But a lot of our disparities are related to the fact that minorities are less likely to receive any type of specialty care. So if they find themselves pregnant out in a rural area of Missouri, if they don't have a local provider because of transportation problems, geographic location, the fact that they may not have insurance, the fact that they may be undocumented, Hispanic, and afraid to actually go to the doctor, that actually puts us at a greater risk of bad outcomes within pregnancy. So there's certainly a large need for collaboration, integrated collaborative teams of both high risk doctors that can handle specialty care answers, as well as those type of doctors that are dealing with these problems on a daily basis. That's why when we put together our specialty team, it included high-risk specialty, family practice doctors that are seeing these patients in rural areas, as well as those that are in the education and medical home type teams. So understanding what a good medical team is important. The high-risk OB is actually going on Thursdays, the first and the third Thursday of every month currently from 12 until 1. There's registration. It is a classic echo format. 20 minutes worth of didactic education, trying to make sure that we're meeting the needs that the state has identified as high-risk areas within pregnancy. Then dealing with actual case-based learning presentations with the typical case discussion, going out to our spoke sites, coming back into our hub team and giving them recommendations. So it does require an awesome team. The team here for OB is maternal fetal, OB-GYN, family practice, and social workers from the Oklahoma Healthcare Authority that can identify local resources to individual counties that are out there. High-risk OB, again, this echo is increasing the high-risk OB guidance, mentoring support, all maternal outcomes throughout all 77 of our counties. It did come out of a $900,000 grant coming out of the Department of Education, or the Department of Health, and the Mental Health and Addiction Medicine Group. So it's $900,000 that we received for the next 3 years to launch this program. The didactic curriculum has actually taken a look at what are those areas that seem to be the highest morbidity, mortality aspects. And so we're starting with hypertensive disorders, we're dealing with hemorrhage, we're going to deal with mental health related issues of depression, anxiety, postpartum depression, racial issues, obviously obesity, opioid addiction, HIV viral disorders, diabetes, trauma, and pregnancy. All of these things will be discussed over the course of the didactic sessions. Certainly from the telehealth network here, we certainly invite you to participate. Anybody is welcome on these related echo lines. We will give best practices that come out of the national organizations, meaning the American College of OBGYNs, the Perinatal Task Force, the Angels Guidelines programs, to put those back into recommendations for our individuals. But it will be up to the local doctor to also find some of the resources if they're empty. With that, I'm going to turn it back to our host. I'm going to stop sharing this program, which we threw together in 5 minutes this morning.
Thank you, Dr. Johnson. That was a wonderful presentation on the echo. I'd like to just take a second because we didn't introduce everyone before your talk. I'd like to get, we'll introduce our hub team and then we'll go around the virtual room and let all of our participants introduce themselves as well. So my name is Rachel Mutro. I'm the director of the Missouri Telehealth Network. I'm the state program director for the Heartland Telehealth Resource Center and also director of the Show Me Echo program. And we will just take turns with the hub team. And Evelyn Nelson, would you like to go next?
Good morning, everyone. I'm Evelyn Nelson. I'm a pediatric psychologist at the University of Kansas Medical Center and PI for the Heartland Telehealth Resource Center.
Thanks, Evelyn. Karen?
Karen Edison, Senior Medical Director for the Missouri Telehealth Network and the Show Me Echo program here in Missouri.
Thanks. Heather?
Good morning, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS.
Robert?
Hi, I'm Robert Stiles with Department of Pediatrics at K School Medicine and work with the Heartland Telehealth Resource Center.
Thanks, Robert. Cece, everybody probably knows you, but you want to introduce yourself real quick?
Yes, I'm Cece Vangel, and thanks for your patience. I completely skipped the introductions.
No problem. Trika?
Hello, everyone. I'm Trika Young, and I'm here at Missouri Telehealth Network, and I'm one of the outreach coordinators.
Thank you, Trika. Let's see, Dean.
Good morning. Dean Anderson here, one of the outreach coordinators. It's great to be here.
Morning, Dean. Joe Kingsbury.
Well, good morning. Joe Kingsbury, Associate Director of Operations for Missouri Telehealth Network and Show Me Echo.
Great. And now we're going to go around and have some of our participants or all of our participants introduce themselves. And I apologize if I don't get your name right. And some of you I can't see, so I'm just going to call on you. But let's start with Ahmad. Are you there? We can come back. How about Dr. Cunningham?
I'm Mila Cunningham, a physician in Columbia, Missouri.
Thanks. Kristen?
Kristen Ash. I'm the family nurse practitioner at William Wood Student Health Center in Fulton, Missouri.
Thank you. Welcome. Deborah?
Hi, I'm Deborah Funk. I'm the Director of Practice with the Missouri State Board of Nursing. Sorry, my camera on my computer doesn't work.
No problem. Thanks for joining, Deborah. Ray? Ray Hayden? We can come back to you, Ray, or just unmute when you can. Helen?
I am a retired physician and I volunteer at the Social Welfare Board in St. Joseph, Missouri.
Thanks, Helen. Barb Gleason?
I'm Barb Gleason. I am the project director for the Southeast Missouri Our Moms Food Hill Perinatal Network.
Thank you for joining. Jill?
Good morning. I'm Jill Sigliana, an occupational therapist and program director of Memory Care Home Solutions in St. Louis, Missouri.
Thank you, Jill. Amber? You're muted, Amber. Hold on, we'll get it.
There we go, got it. Hi, I'm Amber Richardson. I'm a clinical psychologist at Missouri Highlands Medical Clinic in Poplar Bluff, Missouri.
Thanks for joining, Amber. Gerald?
Wow, I didn't change my name. I go by Jerry. I'm Jerry Wellmus. I'm a primary care physician in Maryville, Missouri. Thank you.
Great. And I should know that by now, Jerry. But okay, I think that's everyone. So at this point in our program, now that we've already had the didactic, I think we do not have a case today, Dr. Johnson. So I think what we're going to do is open this up to Q&A. But I think that I will get started with this because one thing that this particular echo, it's called Telemedicine Echo. And our goal is to help people understand sort of the tricky pieces about telemedicine, because we at the Missouri Telehealth Network, we operate a bunch of echoes from Missouri also, but we do think that telemedicine and echo should really go hand in hand. In a perfect world, they would go hand in hand, where the most difficult patients obviously still need to see their specialists, but while many of them can be treated and cared for by their primary care providers. In the case of high-risk OB, one of the questions I have for you, Dr. Johnson, is, are you seeing increases in the amount of telemedicine taking place for these patients? And are you able to do most everything that you would do in person over telemedicine?
Sure. Well, very good. Well, let's go ahead and talk about what obviously COVID certainly did help launch a lot of capabilities. I think once we saw COVID hit back in January, and certainly from the standpoint in Oklahoma, getting the support in the beginning of March, we quickly realized that rural communities did not have, one, the specialists. The second thing is a lot of times they did not have the telemedicine related equipment. Obviously, the monies that then came out to Washington to individual states was able to help us to identify that. Brett Stover is our individual that kind of handles a lot of our clinics as well as rural telemedicine related contacts. What they did was initially they took the highest 15 counties that were lacking specialty related care, and they put telemedicine carts at each of the points of entry, basically the emergency rooms, the critical access hospitals. They worked with the Oklahoma Hospital Association as well as the governor's surge team. By putting those telecarts in there, it gave us the opportunity to do face-to-face telemedicine consultations with pregnant patients, as well as a host of other medical related needs. So for pregnancy, generally speaking, what we can do is everything that you can do in your clinic. Obviously, you have to trust the local provider to be able to get you accurate information that you need to make a decision. With our telecarts, we have been able to transmit ultrasound related findings. We can do that in a live frame time point to where if we're doing a biophysical profile on a patient, we can say, no, you've got your probe, you know, a little out of whack there. You need to turn it a little bit more cephalad for us to be able to see the structure that we need to see. So those real-time face-to-faces are great. From the standpoint of getting fetal heart tones, yeah, you can have a local provider that's giving you a fetal heart tone, but they're certainly not picking up accelerations or decelerations on a monitor. They can put them on a monitor, and then they can certainly show us through secure fax lines and that to where we can take a look at them and say that it's okay, or say, no, this does not appear to be a reactive fetal heart tone tracing. Please put them on an ultrasound and let us take a look at the parameters for a biophysical profile. Obviously, the main things that we see is that when you're in a very rural environment, I mean, if you're all the way out there in Guyman, in the panhandle of Oklahoma, for you to send somebody to Oklahoma City or to Tulsa just for a potentially 20-minute non-stress test, obviously very burdensome in that to try and keep those resources locally. One of the things about ECHO that's been good is obviously the data collection. And within data collection, what we have personally found, and maybe Karen can speak on this effect also, is that if we can keep a patient in a local environment with just their local provider, that's a savings in our state of $1,178. Well, if a practitioner for a topic that he learns treats one patient per month, that's a practice savings of about 12 grand, you know? That's a big savings when you start talking that we've had over 30,000 participants, you know, on ECHO-related programs. Another question, or hopefully that answered your question.
Yeah,
Well,
I think
and I would,
go ahead, Karen. Go ahead.
I was just going to add to that. You know, I always say with our high-risk OB echoes that we've had, we've combined our urban and rural now, and it's called Missouri Moms and Babies, because we found that some OBs and some family docs who do a lot of deliveries didn't think of some of their patients as high risk. And so they thought of that as like, you know, full-blown eclampsia and things like that when they have a lot of obese, diabetic, you know. So we changed the name to Missouri Moms and Babies to get more involvement. But I also was going to say, that I always say, if you through these echoes and through telemedicine with high risk pregnant women, if you save one baby from spending a month in the ICU, you've saved the cost of the whole program.
Oh, absolutely. I agree with you 100%. And I think that's one of the big things that we're seeing now about recognizing and treating opioid-related disorders in pregnancy. Because if we can get a mom started on a good, solid clinical psychological program along with medical assisted therapies in the pregnancy, it's going to decrease NICU time and neonatal abstinence syndrome. That's a humongous savings to a system. I see Barb is asking a couple of other questions here. Who staffs the telecarts? The telecarts currently are handled through our Oklahoma has a very extensive rural network. Our rural medicine network, our rural residency programs, our hospital engagement, it's very diverse program, but Rhett Stover kind of handles that along with Mark Woodring. And what they do is they place the carts, they train on the carts, they try to make sure that they are in accessible locations to get the most bang for the buck. Would health departments be a good place for telecarts? Certainly if the health department is doing any particular type of OB. We do have, I was the department chair for obstetrics and gynecology. I hired an individual named Lance Fry. He then became the department chair. He has now actually moved into the commissioner for health for the entire state of Oklahoma. So he is also an OBGYN. And yes, we are actually trying to put together best practices throughout all of the public health departments. A lot of the health departments are great for vaccines, for general screenings, for determination of pregnancy, for getting them on WIC and social service related services afterwards, but they're not really doing the local OB visits. I think we're still finding that, having things in hospital related systems, that's usually where a patient's gonna go when they see that they have a problem with a pregnancy. It's usually the place that they go for their ultrasounds, the place that they go maybe for laboratory testing. So I think the greater we can place carts in access points like that is good.
Can I just ask you, if you've got, dozens of counties without access to OBs, then how are they supposed to access the prenatal care? I mean, I heard you say that if they're having a problem, they can drive, miles and miles to get to a hospital. But have you thought about how to bring the prenatal care into those counties that are healthcare deserts?
Yes, and actually, there's two individuals at the State Department of Health that work under Commissioner Fry that are looking at these issues. How do you get the engagement? Well, it's like anything within medicine, it takes money to get the results that you're looking for. So you've got to have people see the needs analysis to begin with, take a look at what the solutions are for it. Within the solutions, obviously, there's equipment needs as well as personnel needs, and there's also reimbursement needs. Me personally, as an associate dean of ECHO, I do my ECHO thing. I haven't had to send out a pregnancy-related bill in 3 years since I did my last delivery in March of 2017. And since I've been able to sleep a full 8 hours every single night since that period of time. I figure I did my 5,000 deliveries plus, it's time for the next generation to stay up at night.
Yeah,
but yes, those are great, great questions. And
so I have more of a little bit more of a technical question about the carts themselves. When you're choosing a cart system for a diverse group of hospitals, what goes into that decision? Because I would just say that many of the technologies today are proprietary and they don't talk to each other. So if you put a cart system into a hospital owned by this company, they may already have a different cart system, and You see what I mean? So it could get complicated. So how do the doctors on the other end know which system to log into?
Joe Johnson, well, I hate to say that I'm not the right person to ask this question, but I'm not the right person to ask this question. I really need to have like Mark Woodring or Rhett Stover here, because they purchase the carts, they place the carts, they check the broadband within the communities, they do the local training. I'm gonna beg to my colleague, Heather, do you know anything different from that standpoint on how they made the cart selection, or because?
From my understanding, Telehealth Solutions, which is the third party that Rhett works for, they went through and trained everybody. Beyond that, I'm not really sure how the decision was made. I apologize that I can't give you more information beyond that.
Well, the only thing I can say is, gee, we've got the specialists on this team that we could put you in touch with, and you can certainly bring them back and quiz the heck out of them.
Yeah, I just know from a standpoint of a state with many different hospitals owned by many different organizations, that if you just put a freestanding cart solution in an emergency department, but the specialists are in an organization that use a different technology, typically it seems like a very complex problem with a complex solution.
Rachel, that is absolutely true. We see the same thing with the electronic medical records from hospital to hospital and clinic to clinic. And I think there's going to eventually, from a federal standpoint, somebody's going to have to say, hey, all these individuals have got to be able to link in and be able to talk to each other through some type of a portal. Obviously, it seems like Oklahoma right now, the major portal is obviously My Health. A lot of the hospitals and that will drop their information into the My Health system to where you can access it, patients can access it. But we've all got to be speaking a common language. You know, we have a tough enough time talking to our Hispanic population, to our Laotian population, to our, you know, we've got enough intermixing languages within this country where it makes difficulties just to be able to communicate. So yeah, we're going to eventually have to have a single system.
Yeah. So I'm going to put somebody else on the spot a little bit. Barb, as someone who helps run the program in the Boot Heels part of the state of Missouri, could you give us some of the experiences that you've seen during COVID? Has telemedicine really helped some of the pregnant moms in your area?
So it was very interesting to find out that, because there are five different hospitals in our region that serve pregnant moms of some sort, that some just did not do any kind of telemedicine during the COVID stuff. They, moms that were healthy just were out there hanging out, and the other ones went to the ER when they had problems. So that was a little alarming. Many of the other organizations did do telehealth, but on a call just last week, we were told that they're finding that insurance is starting to push back on paying for telehealth because COVID is under control. And so we're not really sure where that falls right now. What we've found in the research right now is that it's not the Medicaid clients, it's more of the private insurance that are starting to push back. But then the other hospital 5 miles away says they're not having any difficulty at all. So don't really know where that is landing, but it has been very interesting, and our landscape is really changing because a physician who delivers a large number of babies in the Boot Hill has changed their primary hospital or location. So we'll just have to see how that pans out as we move forward.
Joe Johnson. Well, certainly from the standpoint of pregnancy, obviously, generally speaking, pregnancy is pretty much a benign process. You get pregnant, you handle it for 40 weeks, hopefully you have a great delivery and no problems. Women have been doing it for tens of thousands of years. But obviously the cost is really incorporated into those patients that are identified with high risk, either maternal disorders, medical disorders, or opioid related disorders. What we see coming out of the federal program, especially into those that are adding money into these type of grants, It's individuals that are going to provide quality education, not only to the mom, but local providers. It's going to be handling these high-risk pregnancies from the time of their pregnancy, instead of getting them at 35 weeks and they're delivering and all the damage has been done and there's not a lot you can do about it. The next part is substance use disorders. I mean, we have so much addiction-related things that affect a lot of the high-risk pregnancy, as well as the costs within the NICUs. Wraparound care, making sure that women are being able to keep their babies instead of them going off to a social service and a home outside of the family. And getting good engagement of the prison and court systems for women in pregnancy. So if we can look at that whole perinatal quality wraparound care, and if we can do it through echo-related education for the providers in the communities, telemedicine to be able to handle the instant, I've got a patient here with this, what do I do with them? You know, how do you do Suboxone prior to pregnancy? How do you deal with methadone inductions in pregnancy? That's certainly where we need to have these contacts and these collaborative capacity building programs.
That's wonderful. Thank you for those words of wisdom about how we should really be thinking about pregnancy and high-risk pregnancy. I will open this up for questions from other people.
This isn't a question, but I will say that especially with issues of opioid use and other substance use disorders in pregnancy, you know, every rural local area is different. And that's why echo and telemedicine are so important, because it's the local healthcare providers who know the resources in that community, know the infrastructure, know the culture, know how to, know what's available for that patient in that community. And I really think healthcare is best if it's regional, if not local.
Thank you. So I know there are some questions in the chat. And so Joe, can you help us share some of those?
Sure, I can. The first question in the chat, Joe, is back to your presentation. Who staffs the telecarts that you're using? Would a health department be a good place for the telecarts? And have you seen any recent change in telehealth payment? We have 2 hospitals within 5 miles of each other. One says they're getting pushed back on payment since COVID is, quote, under control, and the other hospital has not seen any issues with payment. This is from Barb Gleason. And Barb, I think maybe you addressed some of this in your talk earlier. Did you get all of the answers you were looking for in that particular chunk?
Yes, I did.
Okay, perfect. Thank you. I didn't mean to be redundant. There was another question here in the chat from Evelyn. And Evelyn, did you get your answer yet for this particular question that you posed?
You know, I know you touched upon some of the telebehavioral health with opioid use disorder. My question was around, have you seen telebehavioral health or telemedicine interventions for pregnant parenting moms, for example, around postpartum depression?
Joe Johnson. Certainly, we are very interactive. Our echo lines have a lot of individuals that are faculty of OSU, so they kind of know each other and they work with each other. Our addiction medicine, mental health related echoes talk about pregnancy related models. Within our OB, we bring our addiction and our psychiatrists, psychologists, social workers into those for part of the curriculum development in that. So I think it's very important that we do have behavioral health related issues. I mean, it is part of what we're trying to get out there, taking a look at ACEs guidelines and things for adverse child experiences. Obviously, a lot of these individuals, especially with early related pregnancy, it's because of those things that happened in childhood, abuse related issues that happened in childhood. One of the things I tell my patients or tell my residents all the time is ask those open-ended questions to where they can spill their guts as they would and be prepared to be able to handle it, because there are a lot of hurting women out there from abuse-related issues and traumas that occurred in childhood. Hopefully that answers that.
Yeah, thank you.
And Rachel, that's all the questions that I see in the chat at this point.
Okay. Well, does anyone have any other topics around or questions around this particular topic? I guess I do have just one more thing for us to think about. I saw a report this morning that African American babies are 3 times more likely to die than babies that are white. And I wondered if, Dr. Johnson, I wondered if how you guys in Oklahoma are thinking about the differences in mortality.
Wow. Well, the entire state is actually put together through OPEC, the Oklahoma Perinatal Quality Task Force, a program to take a look at all of these related issues. They've broken it up into 5 specialty arms. One of those specialty arms is looking at diversity, disparity, and ethnicity as part of the problems. I think as we have put together our team, we've tried to be sensitive to that. We've brought on a African-American family practitioner that does OB, works a lot within the diversity areas and areas of disparity within our north part of the city, which has been ignored for years. I think a lot of this is, again, it's education. You know, I look at ECHO. My whole philosophy has totally changed. I mean, it took me 22 years to deliver 5,000 babies. I've touched more lives with ECHO in 3 years than an entire career doing it that way. So if we can increase the educational standard, it's how do you get people out of poverty? You give them education. How do you get people to increase to the next level of social status? You give them education. How do you change the problems within rural America? You've got to give them education. And that's where I think Sanji Arora, because of this ECHO model, should get a Nobel Prize at some point in his future, because how many lives have been impacted through ECHO internationally? You know, I am concerned, quite honestly, just about Oklahoma. How do I get the best practices out there in the hands of the individuals that are on the front lines of care? And that doesn't, and it doesn't matter. Is it psychiatry? Is it endocrinology? Is it rheumatology? Is it asthma? Is it, you know, ACEs guidelines in schools, dealing with nurses in our education system? Whatever we can do to increase that total standard is what's going to change the outcomes and move the needle. As our Governor Stitz constantly says, he wants to move the needle, take us out of the bottom of the states, put us into the top 10. And it's going to require everybody doing their part, but sometimes they've got to have a little bit of knowledge to be able to make a difference in their own community. End of my soapbox.
Thank you for that. Barb, did you?
Yeah, so I absolutely understand education is a lot of what we need to be doing, but in our rural communities, those that access education move away. So we have dying communities, and then they come back later in life when they need to come home to take care of parents or grandparents. And so then they get into these initiatives later in their career. But how do we provide education for communities and keep them in their communities to make them better?
Well, what I say when I sit on the panels with our senators and everything else is, you have a local body of individuals within a rural county, a rural town, that are people that love that town, that have stayed in that town, that have lived in that town. I mean, take a look at old Doc Jones. You know, Doc Jones has been practicing there for 20 years. The problem is Doc Jones is practicing 20-year-old medicine because he hasn't had the opportunity to get out to CMEs. If he does go to a CME, he doesn't know how to implement it into his local area. That's where ECHO comes in. It's that mentorship modeling of going back through residency. It's having somebody that's willing to take that information, be willing to share his successes or her successes or their failures. More of us learn through our failures than we ever do through our successes. I've got 5,000 babies out there that I've delivered. I've got a handful of individuals that I go, oh, did I goof up and screw up on that case? Well, if I'm willing to open myself up to my peers that are out here and say, this is what I had with a patient. This is how I worked them up. This is what I did. This is what happened with an outcome. Wasn't a good outcome. What could have I learned and done better? That is what I'm talking about of increasing the standard of education. It's the frontline providers that are working within those areas. They're never going to leave. But if I can increase the standard of care to that of an academic center in Hollis, Oklahoma. Hollis, Oklahoma is a little whistle stop of a town that's got one red light on the far west-south border of Oklahoma that used to belong to Texas, and the river changed. And Texas said, we're not building a bridge over the river. Let's just give that property to Oklahoma. So, you know, what do you do with those individuals? You have to support them by coming alongside them, putting your arm around them, saying, hey, this is kind of what we see as best practices in education. You can implement that. We can give you resources. We will stay and walk with you with this patient until they have it under control.
Thank you for that. I think that's a great model to try to encourage us to get out to our friends and providers in the rural parts of the state. I think that we are going to go ahead and wrap up today's ECHO session. Dr. Johnson, I can't tell you how much we appreciate you coming and sharing all of your expertise with us. It's been really, really wonderful to hear about the successes that you've had in Oklahoma with your legislature and just the acceptance of the program throughout the state. And it's great to also hear about how you have been able to use telemedicine to supplement, or either way, ECHO and telemedicine, again, we believe they go hand in hand.
I
So,
hope so too.
yes, so thank you everyone, and we will be back here in 2 weeks with a different telemedicine topic.